Hello, I'm Claudia Chiriboga. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the CMEOCast. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. As mentioned, I'm Claudia Chiriboga. I'm a professor of neurology at Columbia University Medical Center, Division of Pediatric Neurology in New York. I am pleased to be joined today by Alan Pannier, who is Head of Clinical Services at SmithRx in San Francisco. Welcome, Alan.
Good morning. Happy to be here this morning with you.
Thank you. So let's start by reviewing our first learning objective, which is to identify the genetic and clinical assessments for diagnosing SMA and outcome measures for monitoring disease activity and treatment response. As many of you know, SMA is a progressive recessively inherited neuromuscular disease characterized by weakness and muscle atrophy due to loss of spinal cord motor neurons. Its genetic defect is an SMN1 mutation, and it's one of, or at least was one of the leading genetic causes of death in children, second only to cystic fibrosis. The carrier rate in average it's about 1 in 50, and the incidence is about 1 in 10,000, though it varies widely depending on race, ethnicity. And in pediatric SMA, there are 3 phenotypes, SMA type 1, 2, and 3. So before talking about the genetics of SMA, Alan, how familiar are most payers with the genetic basis of SMA?
That's a great question. I would say that SMA is no different than many of the other rare orphan diseases that are continuing to receive FDA-approved treatments today. Given the rare nature of the diseases, managed care professionals may not have a strong background in the nature of the disease, but as medications come to market, they continue to go through the drug evaluation process, and payers and managed care professionals become more familiar with the background. In the case of SMA, though, I would say that they're potentially familiar with issues involving the SMN protein, but maybe not, a full background on correlation of how that relates to disease severity.
Okay, so a little bit of background on what the SMN gene does. Well, it is the main provider of SMN protein, without which we cannot live. And it's not the sole provider, but depletion of SMN protein when there is a mutation in the SMA gene causes the disease. And when I'm referring to treatments, we're referring to 5q SMA, classic SMA. There are other types of SMA for which these treatments do not apply. And 95% of cases are due to 5q SMA. Now, it's important to know the role of the SMN2 gene with regards to SMA because it is a disease modifier and has an inverse relationship with the disease severity. The higher the SMN2 copy numbers, the lower the disease severity. And as you can see in a bar graph listed here, there is a wide base, so it's not absolute, but in general, 2 SMN2 copy numbers is associated with SMA type 1, 3 SMN2 copy numbers associated with SMA type 2, and 3 or 4 copy numbers associated with SMA type 3. And I'll talk about those phenotypes momentarily. So prior to treatment, we classified SMA based on ultimate function. That's no longer tenable because of newborn screening and pre-symptomatic treatment. But the ultimate level of function that we had identified 3 types of SMA. SMA type 1, which is the infant SMA, the most common, about 60% of births. And without treatment, it was invariably fatal with about 8% survival at 20 months. They suffer from respiratory problems, swallowing problems. And the way we assess function in SMA type 1 is with the CHOP and 10, developed, guess where? CHOP. And it's a 64-point scale that's very sensitive to motor weakness and motor response in weak infants. We also have used the HINE-2, which is a motor response, which is a much cruder instrument that looks at just motor milestones, head control, sitting, standing, walking. And then the Bayley Scales of Infant Development, which, as we will see, has been used in some of the clinical trials, mostly the sitting item, but also to assess how well children fare with regards to normotypic developing children. And then the WHO motor milestones is another measure, also quite crude, looking at just the gross motor milestones. SMA type 2 is an intermediate form, and they are classified as sitters at some point in time, though they may lose that ability as they age. And their age of presentation is from 6 to 18 months. SMA type 1 is less than 6 months. They have a near normal life expectancy, though it is a bit shortened, and they suffer primarily from musculoskeletal difficulties. With weaker patients, it can affect breathing, of course, and the birth prevalence is about 27%. How we assess response or decline of function is primarily in the US done by the Hammersmith Functional Motor Scale Extended, which is gross motor. It's turning over from side to side, being on all fours, sitting, and of course, walking and climbing stairs and the like. It's not that helpful for stronger patients. For example, an SMA type 3 who is at the ceiling may not show a big response because they're already almost at the top. So other measures will need to be tailored for them. There's also the MFM 32, which is one that has been used for some of the older children and adult studies that have been done. And it's very sensitive, and it has 3 domains. It looks both distal, proximal, and trunk. And then finally, for the weaker type 2, where gross motor function may not be, because of contractures, that easily to detect changes in, it will assess changes in the arms. And that's the ROLM, the Revised Upper Limb Module, has 20 items and is quite sensitive to change. And then we have finally the SMA type 3. And these by definition are after 18 months of age and even into adolescents and young adults that at some point in time are able to walk independently, though they may lose that ability, especially if they present under age 3. They have twice the chance of losing ambulation as do individuals who present after age 3. They have a normal life expectancy. As stated, their SMN2 copy number is 3 to 4, and it's the least common, it's only 12%. To assess function in these individuals, they have to be a bit older in order to cooperate. So at least 4 or 5, they're able to cooperate with the 6-minute walk test. In 6 minutes, how far can you walk? And it is sensitive. You can use the Hammersmith Functional Motor Scale Extended, especially in younger children. But it has that ceiling effect, the MFM 32, and the ROLM can also be used, but there is a ceiling effect with a lot of these because upper body will be normal. So, Alan, I've described very succinctly the 3 main pediatric phenotypes and their mode of assessment. And we use these to determine response. How do payers view these outcome measures, and which ones do they value most?
Yeah, that's a great question. I would say that most payers will be more focused on ensuring that one of these outcome measures is completed for a strong kind of baseline assessment. We recognize that, the specialists are, indeed the specialists, and it's more important that they're using one of the outcome measures they're most comfortable with doing as part of the assessment, as opposed to us trying to enforce the use of one particular measurement. And so really it's a strong focus on getting a baseline measurement and then ensuring that's done over time as well to ensure the benefit of the treatment.
Now, question, do the payers consider stability as a response? Because oftentimes not having that decline in function is as important as having an improvement. Is that something that is considered at all?
Yeah, absolutely. I think that's, really what they're looking at is, is there improvements or, is there the state at baseline, knowing the nature of the disease and that there's, a decline in function without treatment. Showing that a patient is stable over time, I think would also qualify for continued use of therapy.
Well, that's good news because having a lack of progression in itself is an important response. There are some outcome measures that don't make a whole lot of sense. How best can clinicians argue for the use of other measures? Is that written in stone for them? Like you have to do the Hammersmith, nothing else will be acceptable? Or can one make an argument for using some other measure that might be more sensitive, for example, the revised upper limb module?
Yeah, I think that in particular for initial and even the renewal of therapy, I think payers generally, and in particular in our organization, are looking for, again, that stability or improvement as opposed to the actual measure that's being used. I think it's in our mind, as long as it's something that's or an outcome measure that's generally expected, one of the ones that you went through today that are commonly used, in our mind, that's sufficient. I don't put myself in the position to know which one is the best to be done or necessarily the easiest to be done in practice, right? I think that's one of the challenges with even leaning on clinical trial studies and the outcome measures that are used in trials, because there's definitely measures that make sense for clinical trials that aren't practical in the real world. And so to try to force a provider to use one of those outcome measures that are done in clinical studies, even though it's not practical or they don't have the ability to do it in their clinical practice, isn't something that's justified necessarily. So I think we're definitely looking for more just consistency and one that's generally considered an acceptable measure versus trying to force a provider into using one in particular.
That's good to hear. Let's hear some patients and caregivers' perspectives on the process of getting to a diagnosis of SMA.
It took us about 2.5 months to get a correct diagnosis. We were first diagnosed with low muscle tone. We ended up hitting the emergency room at 2.5 months with 2 collapsed lungs. We actually asked them to test them for SMA. We got a great doctor in the ER. We went to the NICU. We were there for almost 2 months, and we did get our diagnosis at that point. So he was about 2 months, 3 weeks old when we got our diagnosis officially. A lot of damage had already been done.
From the time the blood work was done until we got the diagnosis was about 3 weeks. I do not feel that the doctor who diagnosed us was well informed. She didn't know what it was. She Googled it and handed us a printout.
I was diagnosed at 18 months. I started showing symptoms around 12 months old. So it took about 6 months to get a diagnosis, an accurate diagnosis of SMA type 3. And some of my physicians were well informed about SMA. Another physician was not and attempted to get me to do a walk test, which I was unable to do without braces, but he wanted to do it anyway.
So, Alan, what is your perspective on these stories?
Yeah, so when you look at the data available on the therapies that are out there, the data strongly shows that the sooner that treatment occurs, really the better outcomes can be achieved. And so I think there definitely is a need and a push for treating as soon as possible. And we're seeing this through guidelines, right? As guidelines are now recommending SMA screening routinely as part of birth screenings.
That is quite true. And also, it also underscores some of the delays in treatment that many of the patients go through when SMA is not top of the list, with children presenting with respiratory insufficiency or almost losing the ability to walk before someone thinks, oh, this may be SMA. So there should be a low threshold for genetic testing. And it's really easy to do, rapidly done, and should be done first and foremost before large batteries of gene testing are done that takes sometimes weeks, if not months. Okay, so newborn screening, you mentioned, is quite important, and it is now the best way to identify patients pre-symptomatically. It does have its pitfalls. For example, they're all false negatives when they're compound heterozygotes because it only picks up exon 7 and exon 8 mutations. But what are some of the pitfalls in terms of patients who've been identified with newborn screening gaining access to treatment in a timely fashion?
Yeah, with the newborn screening now being added and recommended as part of the uniform screening panel, it does, as part of the Affordable Care Act, make the screening itself a required coverage for individuals that have health insurance, and it should be covered at no cost to the patient or to the family, which again helps increase the access to screenings. But from a treatment standpoint, there are operational complexities around enrollment and getting the child themselves kind of enrolled onto the parent's health plan, which can lead to delays in going through the authorization process. Typically, when a newborn is born, the family has about up to 30 days to enroll the newborn onto their plan for coverage. And prior to that time that it's submitted by the family, the newborn kind of attaches to the mother from like a coverage standpoint. And so because of that, if a child is diagnosed at birth and treatment is tried to be started immediately, it could be that the authorization is attached to the mother's ID number, if you will, in the beginning, but then as they get enrolled, they get their own unique medical ID number, which can lead to issues with coverage and authorizations that are put in. And so there's definitely complexities on the payer side in just how data is organized and how information is processed. And so that's really emphasizes the importance of having this open line of communication between the payer and provider and the treatment center in order to understand who needs treatment and where they're at in kind of the flow of data.
Yes, I had a recent experience where there was a delay in obtaining the baby's insurance. And part of it was a delay due to COVID, just having the birth certificate delays in terms of the governmental response. And then there were issues with regards to whether the insurance company had letter of agreements with the company that you want their medication. And so from a clinician's perspective, what can we do to expedite the process? I think from my end, it's a matter of instilling the urgency of getting the baby on the parent's insurance, but sometimes those aspects are not in their purview. So any suggestions in that regard?
Yeah, I think, as you mentioned, the parents have up to 30 days to enroll their newborn, but if they can do it, as soon as the child is born. And so really expediting that process, I think, does help ensure continuation of coverage, and that when the request is submitted for treatment, that it's submitted under the child itself as opposed to under the parent. And that can remove some of the issues or errors that can occur through the submission process. I also think having the understanding or helping the parent or caregiver know where the medication will be paid for, whether that be the pharmacy or medical benefit, is important as well. And we'll talk about this a little bit later, but that can depend or vary based off of the treatment that's being utilized.
One of my colleagues suggested that we engage the social worker from the hospital where the baby was born to help expedite, because they may have contact with governmental agencies and with insurances to help expedite the process that as clinicians we are perhaps not as savvy in. Going back to the treatment algorithm for newborn screening, most places, most states, because this is a state initiative, the newborn screening, and not all states are yet participant, but a very important majority are, is carriers are not assessed. And some give the SMN1 gene test result, and some give SMN1 and SMN2 gene copy number. And I think that is very important, the SMN2 copy number, because as we saw, the urgency of treatment is different. And we'll see a little bit about this when we talk about the outcome in the pre-symptomatic 2 versus 3 SMN2 copy numbers. So that's important to obtain as soon as possible. And most agree in the neuromuscular community that if you have 2 copies and 3 copies of SMN2 in the setting of SMA, of course, that they should be treated expeditiously, even faster if it's 2 copies as opposed to 3 copies. But when we have 4+ copies, there is some debate as to whether to treat and how to treat. And a lot of that is predicated on the basis of whether we can identify early and how much ground have we lost by waiting. And I think everyone uses their own criteria. My own criteria is that when there is a possibility that the patient may not have SMA, I think we should be a little more cautious about providing treatments that cannot be taken away. Case in point, I had a baby who had 4+ SMN2 copy numbers and went to many places, as many of our New York savvy patients do. And the treatment was predicated on +4. We had time, so we tried to distinguish 4 versus 5 copies, and the baby was found to have 5 copies and was not treated and is now 2 years out and doing very well. Still monitored, still with a lot of surveillance. And of course, the surveillance was much more intense the first year of life than the second, but I think there is a bit of leeway. On the flip side, if a baby has 2 SMN2 copy numbers, there's not a lot of time to waste. And the delays that I was telling you about in New York, where it took us 2 months to get the baby on treatment, we had to wait because the specific treatment, especially the gene transfer therapy, required that we have everything in advance, whereas the antisense oligonucleotide that we'll talk about, we could have gotten the baby started early on if we needed to, and that option was not something that the family took. But my thought is that it's a very nice bridge in SMN2 copy numbers, SMN2 copy numbers of 2, when you don't have time to waste and you want to avoid a suboptimal response. Is this something that the insurance take into account? And if you need to bridge, for example, with an ASO before you go to a gene transfer therapy, is that something that they hold against you, or what are the nuances in that regard?
Yeah, it's a great question. I think it'll, and especially become more prevalent right now that we have 3 therapies that are available. But I think generally the payer community looks at initiating a treatment from the standpoint of, picking one therapy, and that's the therapy that you'll be utilizing. But that being said, I think we'll start seeing some issues or questions arise around switching, and to your point, maybe a bridge therapy prior to setting up gene therapy. When you look at a scenario like that, though, from a cost standpoint, right, where you're potentially using nusinersen, for example, and the loading dose and the cost that's associated with that, and then following it up with a $2 million gene therapy, what's the cost benefit of that? And so I think in many cases it initially could be denied by the payer, but that's where this disease state is so intricate that I think it would require discussions with the payer and the provider, in potentially through an appeals process, but really having that discussion in terms of, this is our treatment plan, this is why we're going with this treatment, this is why we're doing the bridge therapy because of the delay. And I think generally payers recognize the importance of treating as quickly as possible, and even the potential cost kind of savings offsets that come from treating early versus delayed therapy. So it's not an easy answer, but it's, I think, requires almost an individualized case-by-case review between the payer and provider.
So it's not a given, but of course, with some effort, I have seen it being approved, especially in cases where one treatment couldn't be given because of antibodies or because of the bridging that we're talking about.
Yep.
So is there a difference with payers with regards to whether you're already on an SMA treatment, for example, nusinersen, that has been around for a while, and you wish to treat with something else? Is that considered different or a higher bar than if you are for the first time submitting a patient with new onset SMA or a patient found on newborn screening to have the SMA mutation? Do the payers make a distinction there?
Yeah, it definitely would go through a different evaluation or review process. I think that, given the data, I think most payers will be open to initiating treatment, given that they have a diagnosis and they have the genetic testing that's done to confirm it. And then it becomes, what's the treatment going forward? If there's a scenario where switching of therapy is required, I think it would require some demonstration, whether that's through some of the outcome measures to show that the therapy isn't working, or some other form of justification in needs of changing treatment. If you were to look at going from nusinersen to the newer agent Risdoplan, I think that could be an easier kind of discussion or conversation, because the therapy cost is somewhat similar and actually slightly less expensive. And so if they're switching from nusinersen to Risdoplan, it's probably easier to say yes versus somebody that's been on nusinersen and then now trying to move to the gene therapy, just given the kind of upfront costs that have already been invested in initiating the nusinersen therapy.
Interesting. My experience is not quite like that. It seems that patients who are on nusinersen, it is a higher bar that has to be passed in order to switch over to Risdoplan, even though there may be reasons, as you noted, for the change. I do want to make the comment that my own practice is I don't switch just to switch, because there is no head-to-head comparison between the two medications. And if it's not working, as you said, and then it's justified to search for an alternative, that's fine, but it shouldn't be with the idea that we know that one is better than the other, because those studies have not been done. Okay, so now let's go to our second learning objective, which is to apply the latest clinical evidence to evaluate the efficacy, safety, and long-term cost effectiveness of approved and emerging therapies for SMA. So let's provide a quick overview of what the landscape, the mechanistic strategies for treating SMA. Currently, there are two big groups. One is SMN modifying therapy, which includes all the FDA-approved therapies, and have different mechanism of action. For example, we have the SMN2 splicing modulators, and these are medications who increase the amount of SMN protein that is drawn from the alternative splicing of the SMN2 gene. There's a small amount that is made that allows SMA patients to survive, because without any SMN protein, survival would not be possible. And this works to enhance that, and that's nusinersen, an antisense oligonucleotide we'll talk about, as well as small molecules, Risdoplan, recently approved, as well as branaplam, which is another small molecule that's earlier in its clinical trials journey. And then we have another way of increasing SMN protein is inserting a human SMN gene into SMA patients, and that is done through SMN gene transfer therapies. I think that's a better word than replacement, because we don't replace it, we transfer, and it goes where it's supposed to go, which is into the central nervous system. And that one is onasemnogene apoparvovic. I know it's a mouthful. I'll call it onasemnogene going forward. And then there are SMA-independent therapies, which act on muscle. And there are two that are in clinical trials at various stages with some preliminary data that look very promising. And that's the myostatin inhibitors, primarily the SRK-501, which is a monoclonal antibody, and then troponin calcium activators that increase muscle contractility. So just to go over a little bit, and very succinctly, in 2016, you have the approval, December, of nusinersen, and that was followed, newborn screening was approved by RUSP and the federal government in 2018. Onasemnogene apoparvovic was approved in May of 2019, and August of this year, Risdoplan was approved by the FDA. And there are other studies going on, and that includes Risdoplan, branoplam, and the SRK 015, and then phase 1 with a new myostatin inhibitor, which is called B11B110. So let's talk a little bit about these 3 medications before we go to the clinical trials results, so that we're a little more familiar with their mechanism. Nusinersen was approved for patients with SMA of all ages and all types, from newborns to adults. It is an antisense oligonucleotide, it doesn't pass into the blood-brain barrier, so we have to introduce it intrathecally. And there's a loading dose, day 1, 15, 30, and 60, and then every 4 months thereafter per vitam. And there are side effects that can happen because of the ASO going into the bloodstream, and it can be nephrotoxic, cause proteinuria, can have some thrombocytopenia, but most of the side effects are complications of the lumbar puncture, post-op headaches, local pain, and the like. But the ASO itself is very safe. The next one is the gene transfer therapy. We talked a little bit about onasemnogene apoparvovic, XIOI, and that is for patients in the US, it's under 2 years of age. In other places, it's weight. In other countries, it is weight-based, such as in Europe, under 20 kilos. And it's given as a one-time intravenous infusion. It does have side effects. It's a biological agent that transfects many tissues, including the heart and the liver, and it causes transaminitis, troponin elevations, and some immune phenomenon, probably T-cell based is thought, that responds to mitigation with prednisone or prednisolone. And it tends to be self-limited for the most part. And then you have Risdoplan, the small molecule we talked about, but that's for patients greater than 2 months of age. They're doing the pre-symptomatic studies currently. So this is the approval for 2 months and above. And it's an oral medication. It's once a day, and it has systemic distribution that theoretically could have an advantage. It does have some safety warnings, which is mate substrates, the multitoxic and drug extrusion substrates such as metformin, which would interact the Risdoplan with the medication and cause toxic levels, best to be avoided, as well as potentially male fertility effects on spermatogenesis that can improve once the medication is removed, but those studies have not been done to determine how well that occurs, and effects on pregnancy, so it is contraindicated during pregnancy. So let's go to nusinersen, the first trial. And again, there are lots of studies, and there are studies going on. There were some open label studies, CS3A, CS2, CS10, CS12, that I won't talk about. But the pivotal trials is the ENDEAR study, and that is the infant study for infants less than 6 months of age. And what they found was that it improved survival and significantly, and decreased endpoint, which is the need for permanent ventilation. And it also affected motor function. So they had increased survival that was improved by double. It was a placebo-controlled study, the only one done. We won't do that again because there's a window of optimal treatment, and survival and need for permanent ventilation. And then it also improved on the Heine scale of motor scale. It also improved outcome over time. All of these studies, there's a graph that shows that the open label as well as the Endear study all had improvement over time that continued and is continued to be seen as the child were transferred to open label studies. The pivotal trial for later onset SMA, known as the Cherish trial, these were children under 12. The oldest was 9 years of age. And what they found was that on the Hammersmith, as we said, that was the main outcome measure. There was a 4-point difference, and 3 points is clinically meaningful. And these patients have been followed over time in the SHINE study, and you can see that those gains have been maintained and they have continued over time to improve a bit. So what about adult patients, SMA type 3, because the Cherish study was primarily SMA type 2, where there are no controlled clinical trials, but there's a very large German study in adults and adolescents that found significant improvements in the Hammersmith and in the 6-minute walk test that increased over time, so that by 14 months, 40% of those patients, and it was a very large cohort, multi-center, that showed improvement of 3 points on the Hammersmith, and they had a 46-meter improvement on the 6-minute walk test, and 30 meters is considered clinically significant. So the real-world experience of nusinersen has also been noted, and we all have patients, and this is my question that I'll pose to you, Alan, about treatment of patients who do not conform to the clinical trials, and I'll get to that in a moment. I think one of the issues that we have with nusinersen is that because of the scoliosis, that can pose a problem for the lumbar puncture, because many of the patients are children, they may need sedation. My biggest concern was perhaps not having enough medication on board, because it's the same dose for babies and for older individuals and adults. And there's the DEVOTE study that's actually looking at this precise question, because we see patients do so well after the loading dose, and it may not be sustained because of dosing issues. And then there's an unevenness of distribution that may be a concern in some patients that may lead them to want to consider other medications. And finally, let's talk about onasemnogene, which the only one that's been published so far is the START trial, which was the initial Ohio State trial, but that was very powerful. It showed that by 20 months, there were 100% survival and no endpoint. The CHOP INTEND was quite high, and some of them even normalized, and that they actually had a very robust response in terms of the survival curve over time. After the START trial, which was a phase 1, phase 2, came STRIVE, which was the pivotal onasemnogene multi-site study, which is yet to be published, but that found, as shown here, that the survival free of permanent ventilation was significantly improved with the treatment of onasemnogene in this patient group. And it's compared to the PNCR natural history study, which, as you can see, declined significantly over time. So at 10.5 months, which is the median age of being event-free for the PNCR, 95.5% were event-free in the STRIVE study. And by 13.6 months, 25% are event-free, meaning survival free of permanent ventilation, whereas 91% of the onasemnogene treated infants were free of permanent ventilation. Significant response to treatment. Let's talk about side effects. We know that the onasemnogene is given intravenously, so the liver sees a very large amount, and that's where the transaminitis comes. So we need to premedicate with steroids. And sometimes that transaminitis relapses after we're tapering the steroids. Sometimes it can be quite serious. But when you look at the preclinical data, when you give toxic doses of onasemnogene, it does transfect the heart. That explains the troponin elevation, and you can get in these experimental models dilation, cardiomegaly, and dysfunction, as well as thrombosis. And then there is also the possibility of hepatic necrosis that can occur. But for the most part, this is thought to be T cell, but there is recovery thereafter. And finally, and I'm running out of breath and your patience, but let's talk about Risdoplan, which is the newest kid on the block. And this is the oral medication I spoke about. And there are many studies, and they're all called fishes. Don't ask me why. But Firefish is the infant pivotal trial, open, no placebo control group, thank goodness. And then the Sunfish, which is for individuals 2 to 25 years of age. It's the only study that includes adults. And then Jewelfish, which is open label for non-naive patients and is ongoing and mostly exploratory with some efficacy downstream. And the Rainbow Fish, which is the only time I'm going to talk about the pre-symptomatic study for Risdoplan, because it is still very early stages without a preliminary data yet talked about. So when we look at the Firefish data, the main outcome measure was the ability to sit unassisted, and you had 5-second sitting of about 41%, and about 58% had a score of more than 40 on the CHOP INTEND, and holding up their head, 50%. So by and large, it had a very robust response. These were older children with a median of about 6.4 months of age. And we know the earlier the treatment, the better the response. The most common side effects were related to fever, diarrhea, vomiting, and cough. So it has a very mild outcome, and nobody really withdrew as a result of side effects. And when you look at Firefish Part 2, about 30% met the 5-second sitting outcome measure. But I think it's important to note 95% maintained the ability to swallow. And then moving along to the pivotal Risdoplan study, which is Sunfish, these individuals notably were real world. They had significant levels of scoliosis, and many of them severe scoliosis. Many of them had rods. And you could see that the main outcome measure, which was the MFM 32, when you look at the change in 3 points, which is considered clinically meaningful, for all patients, it was 58%. But for the 2 to 11, as we know, these changes are most evident in the younger patients who have less severe disease. It was 71%. And their main outcome is listed here, and there was a change from baseline in the MFM of about 1.55 points, and in the RULM as well, 1.5 something points. So this is a whirlwind overview of the 3 main studies. So now that I've reviewed this efficacy and safety data, can you give me some of the payer's perspective on assessing the value of the SMA therapies? And I think we've talked a little bit about that, but not so much in detail.
Yeah, absolutely. So I think there's just in general looking at, rare disease treatments, there's a number of factors that are considered when evaluating therapies. One of the biggest challenges that payers have is the limited data that's available on treatments. Most of these treatments are FDA approved with small sample sizes, and there's limited long-term data that's available, and even the eligibility criteria to be in the study is fairly stringent. And so it becomes very difficult to, as you were mentioning, how do you take a treatment that's been shown effective under kind of the rigors of this small clinical trial and apply it to the real world? And a lot of the clinical criteria that's developed as part of the prior authorization process is driven by balancing, managing the known data that comes from the clinical trials with the type of requests that will come as the drug is available in the real world. with that being said, in SMA, we know that even though the cost of therapy is substantial, there is a value proposition around offsetting the costs of healthcare utilization, especially in the case of infantile SMA, where you can see that the cost difference is well over $300,000 a year when you're looking at infantile SMA compared to an otherwise healthy infant, but the cost difference being 54 times greater for somebody that's diagnosed with infantile SMA. So we understand that there's a value proposition in treatment, and that the cost of not treating is substantial, right? And so, in taking that into consideration, it's really looking at what's the cost effectiveness of these treatments. And unfortunately, to date, there's limited data that's available from that standpoint. Just given the newness of these therapies, as you mentioned, they're recently being approved. However, there was a study that recently came out that looked at nusinersen and compared the treatment using nusinersen to supportive care alone, and what's the cost effectiveness of using the therapy versus not treating, essentially, and just using supportive care. And it did demonstrate that there was a high cost per quality adjusted life year gained. Typically the kind of standard, it's not widely used in the United States, but the standard is around $150,000 per kind of quality adjusted life year is the standard for a treatment. But that being said, this study showed that it wasn't necessarily cost effective, but the main conclusion was that there's just not enough long-term data available to demonstrate the durability and the cost offsets over time. And so I think as more therapy, or as we get more data on these therapies, these newer therapies, and particularly long-term safety and efficacy data, we will potentially see a shift in the cost effectiveness studies that have been done on these therapies. That being said, one of the unique kind of aspects of these three treatments and this disease state in general, from a payer's perspective, is as you look at treating other common disease states, it's typically that the medications that are used to treat it have similar mechanisms of action or similar routes of administration. And so what's unique here is that we have, for SMA, there's the three main treatments that are available that you've gone over. And they can actually go through individually their own unique routes of payment and distribution. So omnisemnogene, being a gene therapy, is obviously a one-time treatment. You have nusinersen, that's an infusion that's administered by a physician or administered by a healthcare professional on a quarterly basis. And so given that a healthcare professional is administering it, that'll typically be paid for or administered under the medical benefit. And then with Risdoplan, being a daily oral therapy, more than likely that will be submitted to the pharmacy benefit. And so the challenges with that is, many people think of insurance as this one kind of all-encompassing entity that provides benefits, but that's actually not the case. And so depending on the type of insurer, it might be more integrated than others. If you're working with a individual that's on a state Medicaid plan, for example, the submission or the authorization might go to the same organization. But if you're working with a employer group, so a family that's insured by their employer, and the group's self-funded, the employer group themselves actually will end up contracting with vendors to handle the healthcare benefits. And so they'll have a vendor that they utilize for processing or managing the medical claim submissions. They'll have a vendor that they utilize for pharmacy claims, known as a pharmacy benefits manager. And then they could potentially even have a third party that they contract with to handle the medical pre-authorization process that's different than the medical claims payments. And so given that these therapies could go through, various routes of payment, it's very important that these different vendors are coordinating and working together to ensure that the medication is processed timely, but also managed correctly. And so an example of this is in our organization, I work for a pharmacy benefits manager. And so we're primarily focused on managing the pharmacy benefits. And so the distribution or payment of claims that are for typically in an outpatient setting, right? A patient or a member going to an outpatient pharmacy or receiving a medication in the mail from a specialty pharmacy. And so we have in our clinical criteria a requirement for the clinician that's doing the prior authorization review that they have to check with the medical provider to ensure that this request for an SMA treatment has not also been submitted to the medical provider, and also to ensure that the medical provider hasn't already authorized a different therapy. And so ensuring that there's coordination there and not misrouting the payment of the medications. That being said, nusinersen that's typically billed to the medical benefit, as we talked about, and Risdoplan that'll typically be under the pharmacy benefit, omnasemnogene is kind of unique, right? In that it's a one-time payment. It's over $2 million for the one-time payment, and so the manufacturer has established kind of a unique or alternative payment model that's established to help cover or manage the cost of this one-time payments. And so there's various payment models that are set up, and they're still somewhat novel. And so I think the data or the jury's still out on which is the best setup. But you have outcomes-based payment models where the payer would pay a portion of the full price up front, and then as the medication continues to demonstrate efficacy and is continuing to work, then the payer would continue to pay the manufacturer over time, essentially. There's also being looked at an outcome-based rebate model, where the payer would pay, in this case, the full $2 million up front, but as the medication goes over time, if it doesn't achieve certain pre-specified endpoints, then a discount or a rebate would be given back to the payer for the use of the medication. And then what's seeming to be potentially one of the more common kind of payment models for these gene therapy agents, like omnasemnogene, is this outcomes-based kind of annuity payment, where the payer would pay a fixed price over time, and it's spread out over a number of years. And so when omnasemnogene was initially approved, they announced that they were looking at doing kind of an outcomes-based payment over a 5-year period. And that way the payer isn't set with the burden of paying the full $2 million up front. However, again, the payment and the structure of gene therapy is difficult, and so it does lead to some issues with what if you have a member or a patient that you pay for the gene therapy today, and the payer pays $2 million for that cost of therapy, but then the patient switches insurance plans or moves to a different state and is now covered by a different state Medicaid organization. And so their previous payer essentially covered the cost of therapy now for into perpetuity for the next payer to benefit from. And so how do you spread out that cost or that payment? So all of this, kind of the intricacies around gene therapy, I think lend the opportunity, I guess, if you will, for these other two agents that are available on the market. And looking, kind of going along the lines of that and trying to compare the therapies, I think from a managed care perspective, with the jury's still out in terms of preferencing one product over the other. I haven't seen payer organizations yet preference a product over the other, but now that there are 3 products available, it's definitely something that's being evaluated and being discussed. And can you work with the manufacturers to receive additional discounts by preferencing products in this space. In order to do that though, right, you need some type of data available to be able to compare the products and measure them against, one against another. There was an ICER review that was done last year that looked at omnisemnogene and nusinersen and compared the two therapies from a cost effectiveness standpoint. The review found that the value-based price for omnisemnogene to be fairly close to the $2.1 million, and that for nusinersen, the value-based price was potentially needed to be much lower than the current cost of therapy. However, in going through the data, again, there was a press to, or an emphasis on the fact of, given the lack of long-term data, and then also the differences in patient population, that there was really insufficient data to be able to adequately compare the two products, because what drove the kind of cost effectiveness of omnisemnogene versus nusinersen was really driven by the one-time payment versus the continued costs of administration. And then just in general, kind of talking about economic modeling and cost effectiveness, really going beyond the value-based price considerations. There's other payment ramifications that need to be considered. And so regardless of the therapy that's been chosen, it's important to evaluate disease progression and really collaborate with providers on determining what's the most meaningful and practical outcome to be measured, as we've previously discussed, and how do we ensure that the continued use or continued treatment of these high-cost therapies is necessary and is needed on a patient-by-patient basis.
Very interesting. Could I ask, you mentioned a bit about when patients are real world and do not conform to the clinical trials, which are rigorous and designed to optimize the outcome benefit. But a lot of our patients do have pulmonary support, do have tracheostomies, and we know that these medications, I think I'm referring primarily to nusinersen, which has the most experience, shows benefit in those kinds of patients. How does the clinician convey that information to the insurance companies, and do they consider, I know we write letter after letter for the denials for such patients, but eventually they do get approved. What can be done, or what kind of approach is best to take when patients fall out of the confines? I've even had insurance claim that because one medication went to 25 years of age, that a 30 or 40-year-old might not qualify. To me, an adult is an adult, and that's splitting hairs. But what kind of advice could you give in that situation?
Yeah, it's the challenge that payers have, and this, it's not unique to SMA, right? Is the lack of available data and the high cost of these therapies. And so what you'll find is, as you're mentioning, many managed care organizations will set up their clinical criteria to match the data that's available, which is typically, the pivotal clinical trials that got the medications approved. And so, I think 5 to 10 years ago, you would see prior authorization criteria set up to be simply, the medication will be approved if the request is to the FDA labeled indication. And it was kind of as simple as that. But what we're finding now is a push, or maybe not necessarily a need, but a trend moving towards looking at having more stringent prior authorization criteria that looks beyond simply FDA approved indication, and more so that the medication will be approved in the population where it's shown to be effective, which would be the clinical trial data that's there. And so I think especially on an initial request, you'll see, as you're mentioning, those denials where the patient might not necessarily fit into that mold. I think the best approach from a clinician standpoint to kind of overcome those hurdles is, unfortunately, the need to go through that kind of appeal or denial process. But really what we're looking for is submission of, clinical justification, but then also, clinical evidence that the medication will work in this particular scenario. And that I can't speak for every, payer organization, but there's some that will make exceptions to those requests and look beyond, their initial criteria. And, because it's an appeal, look at kind of the whole aspect of the case in general. And there's others that will be, very strict and will continue to deny with the lack of supporting evidence. And so really it puts almost an onus on the manufacturers as well to design their trials or continue to establish or produce data that shows that their medications are effective beyond the data they use to get it approved. And so we are definitely seeing that as medications come to market, as you mentioned, going through the clinical studies that are out there, that a manufacturer will initially get the drug approved through some priority review process, but then they'll continue to do studies to show that the medication is effective in a larger population. Manufacturers that don't do that simply get the medication approved and don't invest in continued clinical trials, I think will have difficulty getting their medication utilized in the market, not just in SMA, but in any rare disease.
Yes, and once patients are on medication, as clinicians, to maintain pre-authorization is to fully document the extent of improvement. And there are things that are not measured on your CHOP INTEND, such as infection rates, ability to handle secretions, voice, bulbar improvement, allowing for speech to be more clear. All of those, I think, need to be documented. And I do think they play a role, even though they're not part of this standard clinical trials outcome measures that we're talking about.
Yeah, absolutely.
Well, thank you, Ellen. That information is very valuable for clinicians. It's an area that for many of us is a big black box. But also it's important to know with regards to the efficacy of treatment, and I alluded a little bit to this earlier, is that it makes a big difference when you treat patients. The timing is very important. And there's a really nice description by Sumner and Crawford describing the 3 stages of SMA: the preclinical stage, where you're not symptomatic, but you're losing motor neurons. The early symptomatic, where there could be a rapid decline. Those are the babies who suddenly develop severe hypotonia and swallowing difficulties, or the child who starts to fall and is clumsy with their SMA. And then after that initial decline, there's a chronic phase. So the subacute phase gives to this chronic phase where there's more of a plateau, but there's a gradual decline over time. So the time to treat is as early as possible. And in that sense, there have been clinical trials in pre-symptomatic children, less than 6 weeks of age, who don't have any obvious clinical symptoms. And other studies have also looked at electrical, at the CMAP, to see that from a nerve function, that the motor neurons are still quite robust and healthy. And there were 2 studies with pre-symptomatic. As noted, the rainbow fish, which is the Risdoplan, hasn't been yet reached a level of analysis, but there is sprint data on a Samogene, and the paper on the nurture study from nusinersen that show that they're relatively comparable in the benefit that is found, and that early treatment does produce a near normal outcome, but that there is a difference between the 2 copy numbers and the 3 copy numbers, with 3 SMN2 copy numbers leading to a normal in most cases. And if you look at those developmental curves, they are in the normal range. If you look at the Heine score for the nusinersen, they do reach the normal range of the standard deviations of the normotypic development. but that the two copy, some do very well, but some are just shy of being normal. So the impetus on early treatment, and we discussed a little bit about this earlier, and we can't stress enough the importance of pre-symptomatic is good, but if you're making a diagnosis, treating as soon as you can, because during that subacute phase where they're losing function, you have to be quite prompt with an SMA type 3 ambulatory child who's losing that ability, as you should with an SMA type 1 who is newly symptomatic. So let's hear a little bit about what patients have to say about how long it has taken to initiate treatment after a diagnosis of SMA.
We got our diagnosis late, and Connor was very weak on the spectrum. I believe the lack of the knowledge that the hospitals had and the doctors had, and the lack of the ability to tell us about treatments and things, I believe that eventually cost my son his life. So I don't think it really could have been any worse.
I actually brought it up to his neurologist. His neurologist knew nothing about treatment, and it took a year, 11 months actually, after it was approved by the FDA to get him injections.
I think the conversations that we've heard underscore some of the frustration that parents have encountered because of a lack of understanding of SMA or not thinking about SMA. And with the treatments that are now available, it becomes even more important to make an early diagnosis, because time is motor neuron. And you may make the difference between having a very good outcome or an outcome that is suboptimal. Alan, what are your thoughts?
Yeah, absolutely. I think from a payer perspective, I don't think there's any question that the earlier treatment, the better, right? I think, as we previously discussed, there are operational issues from a kind of authorization and approval standpoint in getting medications approved for treatment. So there's definitely kind of just an innate kind of barrier to care, but once the request is reviewed, I don't believe that a managed care clinician would have any question in approving a necessary treatment, assuming they have the diagnosis.
We talked a bit already about the difficulties in obtaining payer approval for patients who have reached the clinical endpoint of the various clinical trials. We haven't talked about treatment of patients who haven't been included in the clinical trials, like SMA type 3. And that initially was a concern, but I have not found that of late to be a concern when being treated with nusinersen. Don't have enough of a timetable, but there were SMA type 3 patients treated with Risdoplan, so I don't expect that to be an ongoing problem. But the question I have, and perhaps we can delve a little bit more in detail into this, Alan, is the payer's perspective to switching therapies. And I think switching is a broad term, because for patients who have been treated with onasemnogene, they keep their therapy and potentially their side effects if they're permanent. But oftentimes, in my experience, if they're not treated early enough, may not have such a robust response as one would expect, as we've seen with the SPRINT study when they're treated early. So treatment after treatment with gene transfer therapy, how feasible is that? Is there a need to delay any other treatment afterwards that the payers require?
Yeah, it's a great question. I think, ultimately clinical criteria and these various scenarios is going to vary by managed care organization. I think one of the challenges is, because these agents are so new, there's no data on switching or, adding therapies, I guess, as you're mentioning the case of onasemnogene, if they were to require new therapy. And so in the lack of data and the clinical benefits that would come as a result of doing so, I think that most payers would probably consider a request like this something that would be considered experimental or investigational, and initially wouldn't be covered, and would require some some exception to be made. What's interesting is in the case of omnasemnogene, right? If a patient received the one-time gene therapy and there was a requirement for a new therapy because of a treatment failure, depending on the arrangement that the managed care organization has with the manufacturer of omnasemnogene, as we talked about the different kind of payment structures, right? Is that then considered a treatment failure? And can they recoup some of the costs of the injection or the one-time administration of omnasemnogene to help cover the cost of starting somebody on nusinersen or Risdoplan? And so I think that it makes it more complex given the different parties, but in many cases, if there's a need to try a new therapy, I think that would be part of the review is this considered a treatment failure in my arrangement with omnasemnogene? And if so, can we allow nusinersen and recoup some of those costs? I think, if you look, and we've kind of talked about this before, but if you look at a patient that's on nusinersen and they've received the loading dose, and so they've essentially had that year one high cost of therapy, and now they're in their stable maintenance years going forward, that cost of therapy going forward is very similar to the cost of Risdoplan. And so although, as you mentioned, you're in your experience, you've had difficulty getting that switching of therapy approved, I could see over time as Risdoplan, as organizations become more familiar with the product and have taken it through the kind of thorough review process, I could see them allowing switching of therapy in that regard, because there's not really a cost difference in that point. It would really come down to, does the managed care organization have some form of rebate arrangement or discount arrangement with one of those manufacturers to make it cost prohibitive to switch?
That's very, very interesting. And with Risdoplan, it's actually even less in the younger child because it's weight-based, right? I was told that for someone of a lower weight, that it can be 100,000 or so for infants with SMA type 1. My question is, do we know what the criteria of failure are for omnasemnogene, or is it a big trade secret?
It's a great question. Again, it'll definitely vary by organization. And I do think the therapy is new enough that there's definitely not an established guideline in terms of, this is considered a failure and this is not. A lot of it will be driven at the organization level by the arrangement that the manufacturer has, so that Novartis has with the managed care organization, especially if they're in some form of value-based arrangement, which many of the organizations will be. And so I think that it might vary, but I think, Novartis also will be someone helping drive the definition of failure, because payments will be attributed to that.
And are there any guidelines that you're aware of the period of observation post-treatment with omnasemnogene before they will even consider a secondary salvage treatment?
Yeah, it's a good question. I actually haven't seen any literature around that, so not that I'm aware of.
Okay, well, there's a lot yet evolving, so we'll all be a little smarter come a year from now when we've had some experience in that regard. Let's hear now from patients and caregivers, and this time on their experiences accessing SMA treatment. And mind you that there's a big difference from 2017, when nusinersen just came, right after it came into the commercial arena, where we were all very inexperienced with the process, and how things are now. but some of that still applies to the newer agents.
With our treatment plans, it seemed to me like everything was at first denied. We like denial after denial after denial. Everything about the insurance and everything was a huge hassle. Nothing seemed to go easy for us. We did get a lot of the equipment and stuff eventually, but like I said, it seemed like everything was denied at first, and then we'd have to either make requests or send it in a different way to get something approved.
I would say that there have been insurance barriers every step of the way, whether it has been for a wheelchair or for other breathing equipment or standing frames. And in that regard, the social worker and other members of the care team have been helpful in knowing how to navigate the system to help us work through the insurance process.
Yes, I encountered barriers to getting insurance approval. I was denied twice to get my Spinal treatment, and then I changed insurances and had to get the prior authorization all over again, which was difficult.
So, as we heard, the issue of denials is common, but it is very insurance-based, with some approving without much. My experience with Risdoplan is some approving expeditiously and others denying one denial after another. Can you comment on this from your perspective, Alan?
Yeah, absolutely. I think, the speed to approval will definitely vary by organization, and the normal processes that exist. There are accrediting bodies out there. You have URAC and NCQA that really help establish standardization in terms of turnaround times and review processes of prior authorizations. And so the goal of those organizations is really to help standardize the review process and streamline it so that there isn't delays to therapy and care for individuals. That being said, I think, one of the things we often find in, at least in my organization, is some of the delays in therapy come from really lack of coordination between the various stakeholders. And so it could be that the medication was denied or seemingly denied from the patient perspective, but it was purely because more information was needed or chart notes were needed to be submitted. And that request potentially got lost in the world of faxes that go back and forth, which is crazy to think that, we're in 2020 and we still communicate back and forth via fax to provider organizations, but that's the world that we live in. And so a lot of it that we find is when there are denials, it's often due to just lack of information or issues that come within the process. Information's not submitted correctly, or there's insufficient information to do a review. That being said, these medications are highly expensive when you look at the cost of a normal treatment, and so it's not uncommon to see a delay or to see the medication stopped as it's trying to be approved or submitted so that it can be more thoroughly reviewed compared to maybe a request for a diabetes medication or a cholesterol medication.
Interesting. As I mentioned earlier, with the delay in a newborn screening child receiving treatment, one of the delays was the lack of a letter of agreement between the insurance company and the pharmaceutical. And that took some time. How is that done? Is that done proactively, or do insurance companies wait until they have a client who requires that service to then start that process? And as clinicians, can we do anything to promote them carrying out these letters of agreement proactively so we don't have these delays?
Yeah, I think it's twofold. So depending on the size of the organization, they may or may not be more proactive about it, right? If you're a large managed care organization, then you're probably looking at the SMA treatment landscape, knowing that you'll eventually or probably already have a patient that you're insuring that will require treatment. And so that will, kind of initiate the proactive nature of setting up arrangements and agreements with the manufacturers to get these in place. If you're a smaller organization and you feel that there's not somebody today, then it's maybe they take more of a reactive approach in waiting and until a request comes up, and then figuring it out as it arises. But that being said, I think there is just not just in SMA, but in really any disease state, as payers are working on and negotiating discounts and contracts with manufacturers, there is a delay in that process. Typically, the manufacturers will work with the payer proactively, knowing their medication is been submitted to the FDA and getting ready for approval. But a lot of the actual contractual arrangements and work really can't be done until post FDA approval, because the organization or the part of the manufacturer organization that handles contracting and these agreements doesn't necessarily know what the FDA approved indication will be and the dosing, and really at that point even the cost, because a lot of that's driven by what's decided by the FDA. And so you kind of have this this give and take, right, between the provider clinic community trying to get access to medications as soon as they're available, but then this negotiation and agreements that need to come place between the payer and the manufacturer that really can't start until post FDA approval.
Interesting. Now, and I've heard of cases where certain treatments have fallen through the cracks based on a policy of the insurance company. When something is policy, there's no way to revert that short of changing the policy. Is that correct, my understanding?
Yeah, so there's two different, I guess, setups when you look at a benefit, right, that a patient has. So there's from a medication standpoint, there's medications that are on formulary that are covered part of the benefit, assuming it's medically necessary. And if it's something that is covered, predicated upon it being medically necessary, there is this inherent kind of appeals process, and as we've kind of discussed, the ability to continue to provide more information and justification, and eventually if you push hard enough, you can and provide enough information, you can get it to go from a denial to kind of escalating it through the various level of appeals to getting it to an approval. That being said, if it's something that is a benefit level exclusion or a policy exclusion, that's something that a medical exception cannot be granted for. And so this is more inherent upon how the benefit is set up that the family or the patient has opted into for their care. And so if you think about it, when you sign up for insurance, whether it's through your employer or individually, they'll send you a summary plan document or an explanation of your benefits, and it goes through in very detailed amounts. These are the procedures that are covered, these are the procedures that are not covered, and the premium you pay and your coverage is really predicated upon that document. And so if in that document a procedure, a disease state, a medication is listed as excluded or not covered as part of the benefit, there can't be an exception that's made for it. And that's something that we're actually seeing more and more in the employer space, as you have these really high cost specialty medications that are coming to market. These medications are good examples of it. Employers are having to make tough decisions on whether or not they pay for these medications. And so we do have, in my organization, employers that we provide pharmacy benefits for that have elected to not cover any specialty medications, for example. That's an extreme example, but that's a scenario where if they elect not to cover specialty medications, this coverage isn't covered. And so the requirement would be that the patient or parents would have to go through the manufacturer to try to get patient assistance or get it covered directly through the manufacturer or some other, foundation or grant program that's available.
Well, that's important to know from a parent's perspective, and tricky. It's the fine print. How do you
Yes.
know about diseases that you don't even know your child might have? That's worrisome. And makes me want to stay away from that kind of insurance policy altogether.
Absolutely.
Okay, let's go to our learning objective 3, which is to recognize the individual patient and parent caregiver-related factors that guide clinical decision-making in the management of SMA. And I'll go over this briefly, just to talk a little bit about factors to consider in deciding treatment. So there's some that are patient-related and related to the SMA, as well as the treatment. For instance, the age of the patient. We know that for patients under 2 months, we only have options with nusinersen and onasemnogene because Risdoplan is not yet approved for that age group. It may be after the Rainbow study completes. From 2 months to 2 years, that covers nusinersen, onasemnogene, and Risdoplan. But onasemnogene does not go beyond 2 years of age, so for any patient 2 years and above, the only options would be nusinersen and Risdoplan. There are other preferences, for example, parental preference. I heard some patients, and these I think were adults, who said they couldn't be bothered with taking a medicine every day. They would forget. They'd rather just get the LP 3 times a year and not have to worry. For those of us needle averse, not quite the option we would choose. Then there might be access issues. If it is difficult to access the spine, and even in the best of hands, I've seen even using foraminal injections under CT scans, spines may be very complicated and have hardware make it impossible, even if the patient wanted to administer nusinersen. And there are contraindications, and we know that the main ones have to do with onasemnogene. It has to do, we didn't talk about contraindications, but you can't have high levels of anti-AAV9. And it should be less than 50, less than 25, depending on who you read, but the clinical trials were less than 50. And if it is elevated, you want to wait until that level diminishes. And we say that when it is in the neonatal period because it's mostly maternal passive transfer. That's not the case in the older child under age 2 who may be treated, who has their own antibodies potentially from their own exposure, and those will not diminish over time. And then, of course, if you have congenital anomalies, you might say to someone who has a shunt, would an intrathecal injection be the right approach? I think those dynamics haven't been studied, but now that we have other options, you may say, well, maybe that's not the best distribution possibility for this medication. One aspect that I don't think has been discussed and that I feel strongly about is risk benefit. And it's the severity of the phenotype versus the potentially severe or unforeseen complications. And for all of these medications, I think it only applies in newborn screening when you are dealing with patients who don't have yet disease detected, but who have a mutation and who have a high SMN2 copy number, like the child with the 5 copy numbers, where waiting is certainly an option. But when they're 4 copy numbers, is it justified treating a patient with a gene transfer therapy that may stay with them and might have long-term complications that we yet don't know about? And perhaps my position is colored by an assessment of a 65-year-old grandfather with 4 copies of SMN2 who found that he had the SMA mutation only because his daughter was going through some fertility treatments, and he was totally asymptomatic. Would treatment in the newborn period have been justified in such a situation? So with other options, I think something that you can stop or remove or start as well may be preferable. On the other hand, there's an optimal window for treating with the gene transfer therapy, and if it's needed, you don't want that window to close. And then the issue is, how effective is it in advanced disease? And we really don't know, because no clinical trials have really looked at that, except perhaps Risdoplan, who shows that even in advanced cases, you can have efficacy. Not all patients respond, some just have stabilization, but you see that response. We've also seen it with nusinersen, where these other changes that are often seen can come to play with the breathing, the infection rate, the ability to support themselves upright without having respiratory issues develop. But it is really a conversation that is had between the caregiver, parent, and the clinician, who just provides information. And sometimes parents make decisions based on their preference that we might not agree with, because it might diminish the opportunity for an optimum outcome. So let's hear again from patients and caregivers, this time on their experience communicating with SMA care teams and understanding treatment options.
We felt that we were finding more information when we would go home and do our research. At first, this created a lack of trust and made us feel a little hopeless. We began to build a relationship with our care team, who we had more direct contact with. The best practice they provided was making themselves available to our questions and concerns. But that took a lot of difficult conversations for us to get to that point.
And with the first doctor, which was our diagnosing doctor, she was very unaware that there were treatments very close to approval. The hospital that we are at now is very well informed of everything. They are very SMA friendly.
The voices that we've heard about the families are not uncommon experience, especially when they're initially brought to attention and haven't yet reached a experienced SMA caregiving team, which many multidisciplinary clinics, especially with treatment, have become very well prepared. But in the community, it's not that straightforward. And even sometimes geneticists may not be that well informed. For instance, when clinical trials in SMA were starting, a geneticist told a patient, there's nothing to be done. And this patient could have benefited from the nurture study pre-symptomatically because they were identified early on, and the parents had to fight to get SMA testing done on the infant because I think of lack of understanding. What are your perspectives with regards to the parents' comments, Alan?
Yeah, I think it's important for parents and caregivers to understand the role that the payer plays as well in providing access to available treatment options, right? As they're doing their own research, as they're talking with their care team and deciding, what's considered their best, treatment option for their child, it might not be the preferred product by their healthcare plan. And so, as I mentioned before, I haven't seen it today yet where payer organizations are limiting or preferring one SMA treatment over another, but it's definitely something that could come. And so making sure that they fully understand their benefits and knowing, maybe they decide on gene therapy, but then come to find that that's not an option for them. And so really understanding what treatment options are truly available through their insurer is important.
Those are excellent points. I think in general, it's important to guide patients, but not everyone is as well versed in these treatments. And so it's important to access the family support groups, places like Cure SMA, and others that do have information that has been digested for parents to understand, even if sometimes we as clinicians aren't as user-friendly in providing that information. So to conclude, I hope you've had an overview that has persuaded you in the notion that SMN modifying treatments have altered the natural history of SMA. We've seen patients go from an SMA type 1 who should not sit into sitters, and we've seen patients who should have had SMA type 1 turn out to have normal development. And all of that, the key is early treatment. The best response is pre-symptomatic and faster, especially for SMN2 copies numbers of 2. I should add that because a lot of weight is placed on the SMN2 copy number, it's important to confirm that the copy number is what you think it is, especially if you are planning to have a bit of a delay. There's not so much error in 2 and 3 copy numbers, but with 4 copy numbers, sometimes there is. So it's important to confirm that. But we've seen that early treatment is the best, pre-symptomatic is even better, and that in order for us to affect change on a nationwide scale, we will have to implement newborn screening nationwide, and we are on that road. How does it affect management that we now have effective treatments? Well, we can't dilly-dally with the hypotonic infants. It's important to, as soon as you see a hypotonic infant that could be SMA, that the SMA gene testing be sent off, even though you may be doing additional testing later. If you're not comfortable with that, refer them expeditiously to a neuromuscular center that is. Alert them that you suspect SMA, because that patient cannot wait 2 months to be seen. And that understand, as Alan has pointed out, the many authorization hurdles that we face, that is labor intensive, that there may have to be designated personnel, and that includes the PT, the coordinator, the billing person, everyone participate in an arduous process of authorization and resubmission, and that we not lose hope that you will get approved, because sometimes it's just a matter of being relentless, and that with time that will occur. Oftentimes when there is no treatment in operation at the time, I think we have that leverage with payers that delays will result in a poor outcome, and they have the opportunity of changing that. I think that when patients are already on treatment, that time constraint or urgency does not really apply, because they are, after all, under treatment. But if it's not working for that patient, that assumes a matter of urgency as well. So let's wrap up by reviewing SMART goals that you can carry into your practice, such as ensuring genetic testing for early diagnosis. We talked about the hypotonic infant, especially. Ensure prompt access to treatment, as data suggest that early treatment leads to optimal outcomes. Emphasizing with patients that ongoing follow-up with a multidisciplinary care is important, even with your one-time treatment, even if they've had a very good response, because we need to monitor for durability and for other side effects. Other SMART goals that you would suggest, Alan?
Yeah, in addition to that, I would say coordination with payers on the availability of data for medical necessity determinations. So ensuring that, as we discussed, that the clinicians are providing not only the kind of standard outcome measures, but any evidence of stability or improvement will help as the authorizations are being reviewed. And then in addition to that, having these open discussions or dialogues with between payers and providers around treatment regimens that optimize plan spend. And so this goes along with, the potential need for switching therapies or altering therapies that are kind of beyond the standard regimens that are being requested.
Thank you, Alan. This has been a great discussion that I've thoroughly enjoyed. I hope our audience has too. Thank you for joining us today for the CMEOCast. To receive CME credit, click on the link shown here to complete the post-test and evaluation online. To find additional CME activities, please visit CMEOutfitters.com. Thank you again for participating, and thank you for providing the best care for your patients.